Hi. Our case is on a 57-year-old woman with COVID-19 delusions. I'm Giftlin, and this is Lindsey.
So first, a little bit of background for our patient. Before she was hospitalized for her COVID-19 symptoms, she has a history of major depressive disorder, bipolar disorder, hypertension, which is high blood pressure, diabetes, obesity, and gastroesophageal reflux disease. We do also want to note that 3 times before she was hospitalized in psychiatric institutions, and 2 of these times she had received electroconvulsive therapy.
So initially, she presented to the hospital with myalgia, which is muscle weakness, cough, sore throat, nausea, vomiting, and a tonic-clonic seizure, which is also known as a grand mal seizure. These seizures are, in the first 10 to 20 seconds, there's a loss of consciousness, and in the next 1 to 2 minutes, there's violent muscle contractions, and this was observed during her hospital visit. So these were all symptoms of COVID-19, and she tested positive for COVID, and so she was sent home to quarantine for the 14-day period. But after the 14-day period, she came back to the hospital with persistent cough, shortness of breath, and intermittent anxiety, which were not present during her initial hospital visit. And so she was administered supplemental oxygen, remdesivir, and dexamethasone during her hospital stay now for these COVID-19 symptoms. But after this treatment, her COVID-19 symptoms abated, but then the patient started experiencing confusion, slowed speech, and nihilistic delusions. And these were just completely different than her initial COVID-19 symptoms, and so clearly something else had developed or was already brewing in her, and so the doctors shifted to some differential diagnoses.
So upon arrival at the hospital, she did have, as Giftlin mentioned, the tonic-clonic seizure. So just to make sure everything was okay, the staff did follow up with an EEG. You can see in panel A that there is slight bifrontal brain slowing, and those little arrows are just pointing out artifacts, so like just little noises in the EEG. They did follow up 2 weeks later with an EEG, and we can see even further brain slowing, which is indicative of cerebral dysfunction. We also know that prior to hospitalization, she was taking bupropion, which is a medication that is associated with lowering the threshold for having a seizure. So that could be indicative of why she had the tonic-clonic seizure. Bupropion.
Yeah, what did it do?
It's used for treating affective mood disorders, which she had.
Do you want to go through other medications as well?
Oh yeah, and to treat her seizure, she received anticonvulsants, including levetiracetam, lorazepam, and valproate.
So going back to her nihilistic delusions and her confusion, so the patient, the doctors are exploring Cotard syndrome. So Jules Cotard in the 1880s was a French psychiatrist, and he came up with the term for the syndrome because he had this woman who thought that she was dead, but she was walking around telling people that she was dead. And so up until then, there was no criteria for that in the DSM or any sort of in the medical literature. And so it's characterized as a delusional misidentification syndrome where the patient denies existence of one's own body up to the extent where they think they're dead. And this can be really problematic because these delusions may lead to self-mutilation or suicidal ideation. They tend to starve themselves or just don't take care of themselves because they don't feel that they have a body anymore, or at least missing critical organs. So common treatments are antipsychotic medications, ECT, which is electroconvulsive therapy, which then can be followed with some antipsychotic medications, or transcranial magnetic stimulation. So TMS, transcranial magnetic stimulation, is a non-invasive procedure. It takes anywhere between 20 to 15 minutes, and it just involves like an electromagnetic coil placed on the patient's scalp, and it's just meant to stimulate nerve cells. It's because it's non-invasive, it's sometimes preferred to some of the more, like even ECT is a bit harsher treatment for it, and so patients tend to prefer that. I was kind of skeptical of this, like how can just stimulating nerve cells have any sort of effect, but 50 to 60% of patients who antipsychotic medications either didn't work or was too much for them, they did find improvement after TMS. And so this is just at least a mood stabilizer. It's nowhere a fix for Cotard syndrome, but sometimes it's offered to patients. So in our patient, she experienced delusions that she and others were dead, and also that her bladder had disappeared. This is characteristic of the syndrome where particular organs they feel are missing. In addition, she experienced self-deprecation and guilt over her ability to care for her father. So remember, she was first diagnosed with COVID-19, and at that time, she was a primary caretaker of her elderly father. And so when she got COVID, her dad had also COVID and was quarantining with her. And that she felt guilty over her ability to care for her father and felt a sense of personal responsibility that he got sick. And so she was treated with olanzapine, which is a medication to increase dopamine and serotonin, so just a mood stabilizer and regulator. She refused transcranial magnetic stimulation, and there was just no history of her receiving that treatment. But unfortunately, her outcome, it's unclear if the symptoms abated or resolved at all. So after receiving these antipsychotic medications during her hospital stay, the patient was discharged because she was mostly stable, but she was hospitalized after her hospital stay in psychiatric units numerous times with psychotic features, mainly paranoia and poor self-care. I spent a lot of time looking at the literature for Cottage syndrome to see if there were examples of patients like feeling completely better, like after experiencing these delusions, and there's really not a lot of research because Cottage syndrome is so rare. There's a lot of research on schizophrenia, which has similar delusions, but what's characteristic of Cottage syndrome is the fact that they specifically think that they're dead or are missing certain body parts. And while there is mood management and symptom management, there is really no cure or evidence of patients just completely restoring to prior function.
Yeah, and that kind of leads into our next diagnosis. So the progression of Cotard syndrome, as well as the medication that you take for it, olanzapine, actually can lead to an associated progression of catatonia. Catatonia is a psychomotor syndrome that's involved with your brain, and basically it's really hard for patients to connect their desire for movement and actually carrying out with their motor functions. And this is often associated with illnesses such as schizophrenia, which has very similar symptoms to catatonia and Cotard syndrome, where patients believe that they have thoughts or experiences that seem out of touch with reality. However, she was not diagnosed with schizophrenia, unlike a lot of other patients who have all three, just because there were no lasting, extreme, disorganized, or abnormal motor behavior. And this is because of the common treatments that are available, for example, benzodiazepine. Catatonia is very highly treatable, even with just low doses of benzodiazepine. If you catch it pretty early on, the patient can have pretty much full recovery of their symptoms of catatonia. But if that doesn't work, there's always electroconvulsive therapy that's an option. However, that's obviously a less desired choice for patients. And in our actual patient, the symptoms that she had of catatonia included mutism, stupor, staring, verbal perseveration, and she was just very withdrawn. Using the Bush-Francis catatonia rating scale, it's out of 23. She scored a 13, which meets the DSM-5 criteria for catatonia associated with her major mood disorder. So like we mentioned, she did receive benzodiazepine, which did abate her motor symptoms. However, she was also offered electroconvulsive therapy, but as I had mentioned before, she had electroconvulsive therapy twice before, and she didn't believe that it really helped her at all, so she denied therapy for ECT again. So for our outcome, some of the doctors in our case study actually believed that the COVID-19 diagnosis that she had may have led to an increased risk of catatonia, and this is because of the spike protein in COVID, which is shown to damage the endothelial cells, or the cells that line the blood vessels and regulate exchange of the bloodstream and surrounding tissues, and so that would increase the permeability of the blood-brain barrier.
And so taking all this into consideration, post her COVID-19 diagnosis, the doctors decided that she did have Cotard syndrome, catatonia, and she already had a history of major depressive disorder. And so, again, she was diagnosed with depression, and then not status epilepticus, so she didn't have epilepsy, but she did have that isolated seizure during her hospital stay. Thank you.